Now coming to the endotracheal fiberoptic bronchoscopy. It is performed through the tracheal lumen to ensure that endobronchial portion is in the left mainstem bronchus and there is no bronchial cuff herniation over carina with inflation. Through the tracheal view, you can see the blue endobronchial cuff ideally should be seen approximately 5 to 10 millimeter below the tracheal carina in the left bronchus. It is crucial to identify the right upper lobe through the tracheal view. Going inside the right upper lobe with the bronchoscope, you can see 3 orifices: apical, anterior and posterior. This is the only structure in the tracheal bronchial tree that has 3 orifices. Takeoff of the right upper lobe normally is at the lateral wall of the right mainstem bronchus at the 3 or 4 o'clock position in relation to the main carina. Now coming to the radio opaque marker in the double lumen tube. Here you have the radio opaque markers. This line is proximal to the endobronchial cuff and can be used to position the left sided double lumen tube. It is at 4 cm from the tip of the endobronchial lumen. This marker, when positioned slightly above the tracheal carina, should provide the necessary safety margin for positioning into the left mainstem bronchus. The endobronchial fiberoptic bronchoscopy is used for checking the patency of the tube. It determines the margin of safety, which is for how much for right side and how much for the left side. The orifices of both left upper and lower lobe must be identified to avoid distal impaction in the left lower lobe and occlusion of the left upper lobe. Here you can see the left upper and the left lower lobe. Longitudinal elastic bundles extend down the posterior membranes wall of the trachea and the left mainstem bronchi. This becomes an useful landmark to orient the bronchoscopy to the anterior and posterior direction. There is this elastic bundle helps to identify the posterior part. In the left mainstem bronchus, this longitudinal bundle extends into the left lower lobe and it is an useful landmark to distinguish left lower from the upper lobe. Here you can see the bronchial cuff going into the left side and this is a tracheal cuff and this is the tracheal and this is the bronchial lumen. Now the fiber optic is passed into the tracheal lumen. Here you can see the left mainstem bronchus with the bronchial cuff and this is the right mainstem bronchus. As you advance further through the tracheal lumen, you can see the right upper lobe bronchus with apical, anterior and posterior segment. Then passing the fiber optic through the bronchial lumen, here you can see the left upper and the lower. This is the upper and this is the lower as it is advanced into the bronchial lumen. These are the things which you can see by passing the fiber optic through the bronchial and the tracheal lumen. Now coming to right sided double lumen tube. Right sided double lumen tube is less commonly used than the left sided double tube. Whether it is for right sided surgery or left sided surgery, usually you use the left sided double lumen tube, and this is because of the right upper lobe taking off at an early margin. The safety margin on the right side is only 2 to 2.5 centimeter, but on the left side it is around 4 to 5 centimeter. And the anatomic difference between the right and the left is the right mainstem bronchus is shorter than the left bronchus, and the right upper lobe bronchus originates at a distance of 1.5 to 2 centimeters from the carina. Technique using right endobronchial intubation must take into account the location and potential for obstruction of the right upper lobe bronchus. That is very important. And this anatomic difference are reflected in the design of right lumen double lumen tube. There is a modified cuff and slot in the endobronchial lumen to allow ventilation of the right upper lobe bronchus. Here you can see a slot in the bronchial lumen for the right upper lobe, and you pass the fiber optic, you can see the 3 orifices of the right upper lobe, that is apical, anterior and posterior. As you pass little down further, you can see the division from bronchial intermediates into middle and the lower part. Then as you advance into the left sided, you can see the bronchial cuff going into the right mainstem bronchus, and this is the left mainstem bronchus. Now coming to the indication of right sided double lumen tube, it is nothing but disordered anatomy at the entrance of left mainstem bronchus. You cannot put the double lumen tube because of a anatomical problem in the left mainstem bronchus. This includes external or intraluminal tuber compression of the left mainstem bronchus, or a descending thoracic aneurysm compressing the origin of left mainstem bronchus, or the site of surgery involving the left mainstem bronchus, so the tube has to go into the right side. This includes left lung transplantation, left sided tracheobronchial disruption, left sided pneumonectomy, and left sided sleeve resection. Now coming to the anatomy through bronchoscopy, you have passed the vocal cord, and here you can see the cathedral arch in the trachea. These cathedral arcs are the hallmark of trachea, and here you can see the racing strips on the posterior wall of the trachea. And this is the right mainstem bronchus, and as you enter into the right mainstem bronchus, you can see the upper lobe and the bronchus intermedius. In the upper lobe, you can see the apical and the anterior and the posterior segment, and the intermedius divides into middle and the lower lobe, and inside the middle you have 2 segments, and in the lower part of the right lower lobe you have superior and the basal segment. Totally you have around 5 segments. You have 4 basal segment and 1 superior segment. So it forms 5 segments. And as you enter into the left main bronchus, you can see the upper and the lower division. This is the upper with the lingula, and this is the lower division. And as you enter into the upper lobe, and this is the upper division and this is the lingular division. The upper division has 3 segments and lingula has 2. And as you enter into the lower part, you have superior and the basal trunk, which has about, some books they say 4 segments, some book they say about 5 segments. This is the bronchopulmonary segment through the bronchoscopy. So what are the various problems you face when you insert a double lumen tube? There are 2 major problems. One is malpositioning. The tube is not sitting in the right position. Next, it can cause airway trauma. Coming to malposition. Malposition can cause non-collapse of the operating lung. The operating lung which you are going to operate is not collapsing, causing gas trapping during positive pressure ventilation. It may partially collapse the ventilated lung or the dependent lung and produce hypoxia. So there is going to be non-collapse of the operating lung and collapse of the dependent lung, which may cause hypoxia. The etiology for the malposition is dislodgement of endobronchial cuff due to overinflation, surgical manipulation of the bronchus which can cause dislodgement of the cuff, extension of the head and neck during or after patient positioning, all can cause malposition of the double lumen tube. Fiberoptic bronchoscopy is a recommended method to diagnose and correct intraoperative malposition along with proper recognition of tracheobronchial anatomy. If DLT is an optimal position but lung deflation is not happening, you can pass a suction catheter where lung collapse is supposed to occur. This will expedite lung deflation, but the suction catheter should be removed to avoid including in a suture line. Now coming to the second major problem, which is airway trauma. Airway trauma and rupture of the membranous posterior part of the trachea or the bronchus is a potential complication. Here the etiology is either oversized double lumen tube which you pass with resistance, or an undersized double lumen tube which migrates distally into lobar bronchus, and the main tracheal body of the double lumen tube comes into the bronchus producing laceration and rupture of the airway. Here it presents as unexpected air leak, subcutaneous emphysema, massive airway bleeding into the lumen of the double lumen tube, or protrusion of the endotracheal or endobronchial feed into the surgical field with visualization of the tube by the surgeon. Another potential problem is development of tension pneumothorax in the dependent ventilated lung during one lung ventilation. Bronchoscopic examination and surgical repair should be immediately performed. Now coming to the second common way of isolating the lung, that is bronchial blocker. Here the blockade of mainstem bronchus is done with the blocker. It can be used selectively to achieve a lobar collapse also. Several different bronchial blockers are available to facilitate lung separation. These devices are either within a modified single lumen tube as an enclosed bronchial blocker, where it is called a coaxial system, or it is used independently with the conventional single lumen tube. Here you can see the bronchial blocker placed in the right mainstem bronchus and occluding the right mainstem bronchus, and here it is placed on the left mainstem bronchus, so you can ventilate the right mainstem bronchus. This is the view through fiberoptic bronchoscope just above the carina. Now coming to the two different way of bronchial blocker, that is coaxial inside the lumen of the tube and extraluminal, that is outside the endotracheal tube. Here in the coaxial, it is passed inside the tube and the bronchial blocker is advanced into that particular mainstem bronchus. Here it is passed outside the endotracheal tube and it is called extraluminal system. Coming to the indications of bronchial blocker, it is ideally indicated in previous oral or a neck surgery where the airway can be challenging and still you require a lung isolation for intrathoracic surgery. In this case, you secure the airway with a single lumen tube, either awake nasotracheal or orotracheal, or intubation via tracheostomy. The initial thing is you secure the airway with a single lumen tube and thereafter you place a bronchial blocker to achieve lung separation. And second indications are cancer patients who have undergone a previous contralateral pulmonary resection. In this cases, selective lobar blockade with the bronchial blocker in the ipsilateral side will improve your oxygenation and facilitates surgical exposure. Now coming to the technique of placing the bronchial blocker. Bronchial blockers are advanced over a guide wire placed with the fiberoptic bronchoscope into the required lobar bronchus. Bronchial blockers are most commonly used intrauminal coaxial system within the single lumen tube. The Cohen blocker and Fuji uniblocker can be also placed separately through the glottis or tracheostomy exterior to the single lumen tube. They are extraluminal. The advantages of using a bronchial blocker is you can use a smaller single lumen tube and it is often an option in pediatrics. It can be used when post-operative mechanical ventilation is being considered because of prolonged thoracic or esophageal surgery. It can be used in patients who are prone for an edematous upper airway at the end of the procedure, and where most important advantage is no need to change the single lumen tube if mechanical ventilation is needed in the post-operative period or if airway edema is present. And coming to sizing of bronchial blocker, the smallest internal diameter of the endotracheal tube that will allow the passage of both bronchial blocker and a fiber optic scope depends on the diameter of the bronchoscope and the blocker. For a standard adult 9 French blocker, endotracheal tube size should be equal or greater than 7 mm internal diameter and can be used with bronchoscope less than 4 mm in diameter. Larger bronchoscope will require an endotracheal tube greater than 7.5 mm ID. All blockers should be well lubricated before placement. That is very important. Now coming to the characteristics of 4 main bronchial blockers. Cohen blocker, the size is 9 French, the balloon is spherical and there is a wheel at the proximal part to deflect the tip into the respective bronchus. The smallest recommended endotracheal tube for coaxial is 8 mm endotracheal tube and there is a Murphy eye in the Cohen blocker and the central channel is 1.6 mm internal diameter. Now coming to Arndt blocker, it is available in 5 French, 7 French and 9 French. The balloon shape is spherical or elliptical. The guidance mechanism is through a nylon wire loop that is coupled with fiberoptic bronchoscope. For 5 French, use a 4.5 mm endotracheal tube. For 7 French, use a 7 mm endotracheal tube and for 9 French, use a 8 mm endotracheal tube. Murphy eye is present only in 9 French Arndt blocker and the central channel is 1.4 mm internal diameter. Coming to Fuji uniblocker, it is available in 5 French and 9 French. The balloon is spherical and there is no specific guidance mechanism. It is the pre-shaped tip and you need a 8 mm endotracheal tube for a 9 French. Murphy eye is not present and the central channel is 2 mm ID. Coming to EZ blocker, the size is 7 French, balloon shape is 2 times spherical, guidance mechanism is done. The recommended endotracheal tube is 7.5 mm ID. Murphy eye, there is no Murphy eye and the central channel is 1.4 mm ID. Arndt blocker has a retractable loop that is placed over the fiberoptic bronchoscope, which is then used to guide the broncher, onto the particular lumen. The Arndt blocker will simply advance easily into the right mainstem bronchus without the loop. For left side, you need a loop guidance with the fiberoptic, but in case of right, it just goes inside the right mainstem bronchus. Here you can see the Arndt blocker in the left mainstem bronchus along with the fiberoptic scope, and here the balloon is inflated and the left bronchus is being blocked. Now coming to Cohen endobronchial blocker, it has a proximal wheel that deflects the tip into the distal part of the blocker into the desired bronchus. It is a pre-angle at the distal tip to facilitate insertion into the target bronchus. Arrow at the distal tip above the balloon indicates the direction in which the tip deflects. To position the Cohen blocker, the arrow is aligned with the bronchus to be intubated. The proximal wheel is turned to deflect the tip towards the desired side and then the blocker is advanced with the fiberoptic guidance. Here you can see the 9 French Cohen blocker. The fiberoptic scope is 4.2 mm and the endotracheal tube is 8 mm internal diameter. Now the fiberoptic and the blocker is advanced, and here you can see the blocker is advanced into the left mainstem bronchus and the fiberoptic is used to localize the bronchial into the left mainstem bronchus. Now coming to Fuji uniblocker, it is an independent blocker made up of silicon material. It is a simple fixed distal hockey stick angulation to facilitate insertion. The blocker is simply rotated to the left or right as needed under fiberoptic guidance to placement in the required bronchus. Coming to EZ blocker, it is a recently introduced 7 French 4 lumen catheter with a Y-shaped bifurcation. Each distal end has a balloon that can be divided into left and right mainstem bronchus. The device comes with its own multi-port adapter and used through 7.5 mm single lumen tube. The end of Y sits on the tracheal carina. Each distal tip is positioned into the right and left mainstem bronchus and the appropriate bronchial balloon is inflated in the operative side for lung oxygenation. Here you can see the right and the left. Here you have central lumen, two distinct balloons color coded yellow and blue. There is a radio opaque shaft, and here you can see the bifurcated distal extension Y shape. Depth markers are there, and this is the multi-port adapter which is used at the proximal end. Now after laryngoscopy, a single lumen endotracheal tube is being introduced. You can see the single lumen tube going in. Now the multi-port connector is being attached to the tube, and the circuit can be attached to one port. To another port, you have the fiberoptic bronchoscopy passing in, and through the other port, we have the EZ blocker going in. You can see the EZ blocker going in, and you have the blue balloon and the yellow one. As you inflate the blue one, here you can see the bronchus of the right side is blocked, and when you inflate the other balloon, the left mainstem bronchus is blocked. So you can block whatever bronchus is required. You can see the left being inflated and the right not being inflated. Each bronchial blockers has two distal limb with the buccal balloon that are positioned into each mainstem bronchus and fixed at the carina. Two limbs are color coded, the blue, and here you can see the, not seen clearly properly, but here you can see the yellow one. So it is color coded, blue and yellow, and appropriate blocker is inflated via matching colored pilot balloon. Now coming to the complication with bronchial blocker, there can be a failure to achieve lung separation because of abnormal anatomy or lack of seal within the bronchus. Inclusion of the bronchial blocker or distal wire loop of the Arndt blocker into the stapling line and requires surgical re-exploration after unsuccessful removal of the bronchial blocker after extubation. To avoid this mishaps, communication with the surgical team regarding the presence of bronchial blocker in the surgical site is very crucial. Clearly, the bronchial blocker need to be withdrawn within a few centimeters before stapling. Another potential dangerous complication with all bronchial blocker is inflated balloon may move and large above the carina or accidentally inflate in the trachea. This leads to inability to ventilate, hypoxia, and potential cardiorespiratory arrest unless quickly recognized and the blocker deflated. More pole positions with bronchial blocker than the use of double lumen tube. Failure to deflate at the conclusion of surgery. Here the most important thing is always test the pilot and the balloon prior to use, and that air is injected, aspirated, and the balloon completely deflate. So you should inflate and deflate the balloon before placement and see to that the balloon is working properly. Perforation of the bronchus with the use of easy blockers has been reported, particularly in a patient who has received radiation therapy. This radiation therapy makes the tissue friable, and once you insert the blocker, it might rupture that particular bronchus. One of the blocker tips can perforate the bronchial valve and can be visualized outside the bronchus during surgery. It is very important to advance a blocker with guidance of fiberoptic scope to prevent this type of complications. Rupture of the posterior wall of the left mainstem bronchus has been reported with Fuji uniblocker. This might be due to advanced age, elderly population, or a poor tissue quality compounded by trauma of the preformed distal tip of the Fuji uniblocker and potential pressure as exerted by endobronchial blocker on the entrance of the left mainstem bronchus. If there is any air leak or air packet in the mediastinum with failure to maintain a proper tidal volume after all corrective measures have been addressed, then you should have a suspicion of ruptured airway. Here you should have a direct visualization and inspection during the surgical intervention to localize the rupture of the airway. Now coming to the third option of lung isolation, which is a single lumen tube or an endobronchial tube. If these tubes are advanced into the contralateral mainstem, thus protecting this lung while allowing the collapse of the lung on the edge of surgery. You put it into the particular main stem bronchus which is required, so that part only is ventilated and the other part is not ventilated. But nowadays it is rarely used in adult practice. Rare indications for single lumen tube include difficult airway, carinal resection, post pneumonectomy where there is going to be limited access to the non-ventilated lung, and the last indication is going to be difficulty in positioning the standard lumen tube in the bronchus. It is most commonly used in infants and small children. Uncuffed, uncut pediatric size endotracheal tube is advanced into main stem bronchus under direct guidance with an infant bronchoscope. This is the standard single lumen endotracheal tube, and the endobronchial tube are specially designed single lumen tube. Here the endobronchial tube is longer and the cuff is shorter. It can be used as an endotracheal tube and advance into the main stem bronchus with fiberoptic guidance when needed for lung isolation. So, in summary, to compare all the method of lung isolation. In case of double lumen tube, the option is direct laryngoscopy, video laryngoscopy, fiberoptic placement, or you can use a tube exchanger into a single lumen tube and then place the double lumen tube. The advantages: easy to place it successfully, reposition rarely required, bronchoscopy to the isolated lung can be done, suction to the isolated lung can be done, CPAP and PEEP can be easily added, can alternate one lung ventilation to either lung. Placement still possible if bronchoscopy is not available. You can place it bind. It is the best device for lung isolation. Disadvantage: size selection is slightly difficult. It is difficult to place in patient with difficult airway or abnormal trachea. It is not optimal for post-operative ventilation. There is a potential for laryngeal trauma as well as bronchial trauma. Now coming to bronchial blocker, we have Arndt blocker, Cohen blocker, Fuji uniblocker and easy blocker. The site selection is rarely an issue. It is easily added to the regular endotracheal tube, allows ventilation during placement, easier placement in patient with difficult airway and children, post-operative two-lung ventilation by just withdrawing the blocker. You can provide selective lobar isolation. CPAP to the isolated lung is possible. The disadvantages: you need more time for positioning, repositioning is needed more often, bronchoscopy is essential for positioning, limited right lung isolation due to right upper lobe anatomy, bronchoscopy to the isolated lung is impossible, minimal suction to the isolated lung and difficult to alternate one lung ventilation to either lung. Now coming to Univent tube, the advantages same as bronchial blocker, less repositioning when compared with bronchial blocker, but it is rarely used. The disadvantage is also similar to bronchial blocker. ETT portion has a higher airflow resistance than regular endotracheal tube and there is a larger diameter than the regular endotracheal tube. Coming to endobronchial tube, the advantages like you can use like a regular endotracheal tube and it can be used for placement with difficult airway. It is longer than the regular endotracheal tube and the short cuff is designed for lung isolation. The disadvantages: bronchoscopy is needed for placement. It does not allow bronchoscopy or suctioning or CPAP to the isolated lung. There is difficult right lung ventilation. Coming to endotracheal tube, with the endotracheal tube advanced into the bronchus, easier placement in patient with difficult airway. Disadvantages: does not allow bronchoscopy, suctioning or CPAP to the isolated lung. The cuff is not designed for lung isolation and extremely difficult right one lung ventilation. Thank you.